international scale of a learning health system. I'm not talking about learning health systems on an individual organizational level, but many of the things that we're going to discuss today are also applicable to a smaller level. My background is from evidence, is from guideline development, and I've had the opportunity to work together with people who have developed a learning health system which they call the evidence ecosystem. Many of the things that I'll be discussing today are very much based and very much rooted in this idea of the evidence ecosystem. And the evidence ecosystem identifies 5 main steps in a learning health system, and we're going to discuss all 5 of them, where my research lies in these 5 steps, and what potential projects, what potential next steps could be, and where the challenges lie in each of these steps. And we're going to look at evidence synthesis, where we will look at what was actually the start of my academic career, everything that has to do with guideline development. We're going to look at evidence dissemination. How do we get this evidence into clinical practice? How do we make it available? How can we implement it? And implementation is going to be limited in this case to clinical decision support systems, where I'm very much aware that there's a large array of implementation strategies, which we will not be discussing today. Looking at platforms and infrastructure to allow evaluation and improvement strategies. And then finally, how we can work with a learning health system and how we can use routinely collected health data to create new evidence within the system, which can be applied locally, but could possibly also be applied internationally. And that's where we're going to talk about this new buzzword called real-world evidence. But let's take a first look at evidence synthesis. And evidence synthesis, and that's one of the main key features of this learning health system, is we need timely access to trustworthy knowledge within a learning health system. And very important there is how does evidence influence decision making, and how can we develop trustworthy recommendations, and what are the challenges in those trustworthy recommendations that are international but also national. Now, here's a small teaser, and it's an example that I like to use a lot with students because, and also with GPs, because it's a question, or it's a situation that often arises in general practice. What if a GP or any clinician reads this first article, where he reads that dobezilate, which is a drug treatment for chronic venous insufficiency, and that this study, a recent study from 2016, concludes that the treatment with dobezilate in patients with chronic venous insufficiency results in a volume decrease of the affected leg. And what type of patients are we then looking at? A GP would think about probably also more elderly patients, or sometimes even very elderly and geriatric patients with really swollen legs, sometimes with younger patients, but people who have a problem with big, visible, enlarged ankles. And you have this study article, and how can something like this influence decision making? And I think it's very important that we need to find ways to communicate this to a physician, to a clinician, in a way that it can guide decision making. And one of the things that is important there is we need to be able to inform clinicians with at least, in my view, 5 aspects of evidence, of research. We need to be able to inform physicians with certainty of evidence. We need to be able to inform them with effect size. We need to inform them, or at least make it transparent, what values and preferences are of patients. It could be important to inform clinicians on cost as well, and we also need to inform them on practical issues. And why is this important? And let's go continue with this with the case of the chronic venous disease. And this is a Cochrane review which included the study and illustrates clearly what I mean with certainty of evidence and effect size. We need to be able to tell physicians how certain are we of the effects that we found in these research articles? And we use, and I advocate very much in the guideline development world, and it's been a challenge to get this through, to use grade as a method to illustrate, or at least make quality or certainty of evidence, which is the term that we use more currently, to end users. And there are 4 ratings. You have very low, low, moderate, or high. And in this case, there is a moderate quality or certainty of evidence that these phlebotonics can diminish the edema, or can lower the circumference of the lower leg in patients with chronic venous disease. And that means that we're quite certain that the effect that we're measuring in studies is has the right direction, so it certainly lowers it. We may not be entirely certain of the exact effect size, but it's certainly in this ballpark, and it won't be 100% higher, and it certainly won't be 100% lower. And we also need to be able to tell them what this effect size is. And in this case, it's a 4.27 millimeter decrease in leg circumference. Now, I don't know how many of you actually have ever encountered a person with swollen ankles. These generally, if you measure them, we're talking about measurements and big range of about 15 centimeters. So you can imagine that a 4.27 millimeter decrease is certainly a decrease, but the question is this really clinically relevant? Is it something that patients are willing to take medication for, drugs for, to have this type of decrease? So we need to be able to show them the effect size. What does it really mean to a patient? And ideally, you would actually be able to show it what the influence is, not only in absolute numbers, but also in actual cases. What would be the real decrease from how many centimeters to how many centimeters would that be in actual patients? And we need to be able to tell them how sure are we of this effect. In addition, I think we also need to be able to tell patients, and this is an example from the recent WHO guideline on COVID-19 drug treatments. We need to be able to show clinicians information on those outcomes which patients actually consider to be important. And in this case, the WHO used the grade approach to develop guidelines on several drug treatments, and this is a recommendation on the use of hydroxychloroquine. And they identified, I only showed 4 of them, they identified 12 outcomes together with clinicians, topic experts, but also with patients, which they defined as these are the outcomes that will drive decision-making. For instance, we talk about mortality, the need for mechanical ventilations, viral clearance in 7 days, admissions to hospital. But there were also a series of what we call negative outcomes, undesirable outcomes, and outcomes that are related to this intervention, to this drug treatment, which would potentially harm patients. And this is important because we need to know what the potential benefits are of a treatment, but we also need to know what the potential threats are and undesirable effects of our treatment. And you need to be able to put this in a way, in a scale. In addition, and this is not something that I haven't projected, but we also need to have an idea what the practical implications are of certain interventions. And this could be important. I was involved in a guideline on, for instance, the use of a diagnostic testing in patients who are suspected with gout. And one of the things that is very much advised, or there's a lot of research evidence that it's a very sensitive and very specific test, is aspirating some synovial fluid from an infected joint for treating for diagnosing gout, because we know that there are quite a few people out there taking medications for lowering uric acid who've never had a gout diagnosis, and there are also quite a few patients out there who have recurrent joint disease and who have gout, but they're underdiagnosed. However, taking a sample of an inflamed joint, and typically these are the joints of the toe. This is very difficult. First of all, patients don't want this, and second of all, you need a technical expertise to be able to do that kind of an injection, so or that kind of aspiration. So there are certain practical issues which are also important in these. And so we need to find ways of communicating this type of information to clinicians. And remember the inaugural lecture by Mieke Vermanderen. There are also where we're testing new visual ways of showing these types of numerical and technical information to clinicians so that they can use it in discussion with patients and to guide decisions. There is, however, I think, an important aspect that we need to consider, and I know that many of you may not agree with me there, but many clinicians, they're not interested in all this information. All they want is advice on how to approach in certain situations. And I think we need to be able to guide clinicians away from the type of cookbook medicine which they would like. And in this case, we have a recommendation at the top of the page that says we recommend against administering hydroxychloroquine or chloroquine for the treatment of COVID-19. Based on the fact that the panel agreed that almost all patients, at least the majority of the patients with this disease, would not want this intervention. However, in many cases, it's not that clear, and then we need clinicians to go into this information to be able to discuss this with patients. Does that mean that they need to know exactly how clinical trials are conducted, that they need to know how to do a critical appraisal of an article? My opinion there is, no, I don't think they need to know that, but they do need to know what the meaning is of a certainty of evidence or a quality of evidence rating. And they need to be able to discuss effect sizes with patients, but they don't need to be able to read and critically appraise an article, which is maybe very different for someone working in a research context. Now, why is it important that we have this array of outcomes that we need to include patients to be able to find this method of scaling desirable and undesirable outcomes? And that has to do with the fact that we're often missing what is really important to patients. And this is and I don't know if people know this organization called the James Lind Alliance. But in the UK, the NHS started this organization to be able, for clinical research, include patient perspective on what type of research should we be doing, what are the outcomes that we need to be doing in research, and how does this influence healthcare. And these are done in so-called priority setting partnerships. And what we see is, if you look at the types of research being done, and these are categorized in three colors, where the green are the education and training types of research, service delivery, psychosocial research, things on physical exercise, diet, lifestyle interventions. The red ones are a little bit more clinically oriented. Think about radiotherapy, surgery, devices, diagnostic research. And then you have the big blue blocks, which are drugs, vaccines, biologicals, everything which has to do with medical treatment. And we see that commercial trials are greatly dominated by trials on drugs and vaccines and biologicals. If you look at non-commercial trials, then you see that there is more an equilibrium between the three categories. But if you look at these, what these patient priority setting partnerships define, they find that, or at least patients find, that there should be a lot more emphasis on the education, the psychosocial, lifestyle, and physical exercise type interventions. So where the research world remains somewhat disconnected from clinical reality, and we need to find ways of integrating that. And that's why it's important to go to patients and find out what outcomes are important to you. And when we look at things to inform decision making, how can we connect, and how can we make sure that we're looking at the right things? And so just an illustration of why it's important to implicate patients in all sections of research, including guideline development. major challenge is in this clinical guidelines is how can we, and this is from the Institute of Medicine, the idea of where these guidelines come from, and guidelines again being research oriented, but also have the idea of doing an assessment of benefits and harms of alternative care options. And how can we get these guidelines into practice? But what are some challenges in the learning health system? And I think there are two very important challenges. One is reducing waste, and the other is how can we work with recommendations within a learning health system. When we look at reducing waste, that's something that I was involved at the beginning of my academic career very much, and I still advocate a lot for, especially with students also, is the idea of reusing clinical guidelines that were developed in different settings or different organizations. And the idea there being that evidence is global. What evidence is not something which is local or regional, that's generally global. Recommendations are local, and experiences that I had with guideline adaptation is that in the majority of the cases, not only is the evidence global, but also the recommendations are global. So there is really, I think, opportunities for international collaborations and guideline development where the recommendations can be reused and sometimes slightly adapted to account for a local specific healthcare differences, but in many cases, recommendations are also global. And we need to work on common methods, grade being one. And I think, and that's very important to clinicians, we need to move away from cookbook medicine. We need to work with more conditional recommendations where multiple interventions are possible. We need to inform clinicians on how to discuss this idea of conditional recommendations. How can you involve patients? And again, I referred to the lecture by Mieke Vermander last month. How can we involve them in choosing an intervention which all have desirable and undesirable effects? Recommendations within the learning health system, again, and this is something that I'll go into a little bit deeper later in this lecture. This is the infographic for a recently accepted publication in the BMJ Pediatrics, where we looked at the question, can we make a recommendation using information in the learning health system on opening or closing schools in this COVID pandemic. And we were able to use these grade methodology to come with a very well-structured and well organized panel to a recommendation to keep schools open in most situations during the COVID pandemic. But I'll go into how we did this a little bit later in this lecture. And this was the infographic for this. How do we get this information in a timely manner to clinicians? And this is something that over the last 10 years I've been working on very fervently with the people from EB PracticeNet. And EB PracticeNet is an organization or a platform that was formed about 10 years ago from the idea, or at least from the realization that a lot of entities in Belgium are working on guidelines. And clinicians had difficulty trying to find all these guidelines because they were all being disseminated across a variety of platforms. So the idea was to centralize all these guidelines in a common platform, and to make direct access to this platform from within the electronic health record. And in addition, we supplemented this database of guidelines with an additional 1,000 guidelines from an international guideline developer from Finland. And that's where a lot of the experience came from in guideline adaptation, because many of these guidelines, despite having an international character, needed to be adapted to fit the local setting. And so we have about 1,000 guidelines available on this platform, all translated in Dutch and French. And where necessary, there are additions that are very specific to our local context. Several years later, we were involved in a project that made actual lay translations of all these same guidelines, these 1,000 guidelines, and aimed to inform patients. So all these guidelines are translated in a way that patients understand the meaning of these guidelines, that a lot of the jargon is taken out of the text. And also these guidelines, or these patient leaflets, are available directly from the EHR and can be used as decision aids during the patient encounter. How do we implement this evidence? Like I said, we're going to discuss only clinical decision support systems. And there are a wide array of evidence implementation strategies, which we're not going to discuss today. And because it's outside the scope of this talk and it's outside of the scope of my research interests. But clinical decision support systems are very much a focus of my research the last years, and also will continue to be a focus of research at the Kulak, where data-driven healthcare is the main theme of our small research group. What are clinical decision support systems, and how effective are they? And if we look at clinical decision support systems, we actually identify two main types of decision support systems. I categorize them as a pull and a push system. A pull system relies on the healthcare professional having a question, identifying an information need, and using a decision support system to direct him towards this information. And these are typically info type buttons, which are in Belgium available as what we call the evidence linker in primary care. And I think many other EHR systems have very similar types of applications where a simple button directs clinicians to patient-specific information based on the specific question or the specific topic that has been entered into the EHR. More complex systems are what we call push systems, where the EHR has already sent a data set to a decision support system, and the system from that data set will derive recommendations, will derive actions, will derive reminders or alerts or physician order entries based on a set of rules. And these rules can be either knowledge-based, based on recommendations, based on very simple logic, if this then that, or they can be non-knowledge based. And then we're looking at systems that use artificial intelligence, neural networks, to derive associations from within a large data set and to use that information to make new recommendations or new reminders. What types of decision support systems are there, and do they work? And here I just illustrated some, which some people may know. And some of the research that we've been doing was using EBMEDS. It's a clinical decision support system which is knowledge-based and uses recommendations on a whole wide array of conditions in primary care, especially, but also for secondary care. And generates reminders which are then sent to the clinician in primary care. And this system we also used in a clinical trial on diabetes, which unfortunately did not influence clinical care that much. But there are others. I think the people here who have a background maybe in pharmacy, pharmaceutical research may know Delphi Care, which is something clinical decision support system which is used in drugstores in Belgium. iGuide is a clinical decision support system which aims to support the testing or the ordering of radiological examinations, and that's used across the world, and especially in several countries in Europe. Another one, which I think a lot of people will probably know by name, is FibriCheck, which is an app and that uses artificial intelligence to detect atrial fibrillation in patients, and often using a smartphone or sometimes a watch. But do they work? And then I'm afraid I have to be a little bit pessimistic. We see that many of these clinical decision support systems really don't really actually deliver what they promise, and they do perform under what we expect them to do. And if we assume that in about half of the situations, clinicians follow the most appropriate way of work or line of clinical reasoning, then we see that the clinical decision support systems will increase this with maybe about 10%. But certainly not that high, and we're quite certain of this influence because there's a large history of trials and studies in clinical decision support systems, and a few years ago, we conducted a research on why is this? We did a systematic review of co-interventions that predicted success features of clinical decision support. And in addition, there was also a panel consensus meeting on those aspects that drive success of clinical decision support. And there are at least 4 different aspects that we need to take into account to make decision support work. That you need a context that enables decision support. Appropriate content, that's very, very important, because the trustworthiness of the system is crucial in installing trust in clinicians. And if you see that the content doesn't really agree with how clinicians experience the clinical guidelines or the methods of work, then they lose trust and then they stop using the system. An effective system is also very important, and that's very much driven by data quality. If the decision support is not very patient specific and it tends to give false alerts, then there's something called alert fatigue, where clinicians really quickly stop looking at the reminders because it's not applicable to their patient or it's not important to their patient at that moment. So you need an effective system which is not only sensitive but also very patient specific. And then there need to be some very important implementation strategies alongside decision support, because as I said in the beginning, decision support alone is only one of many implementation strategies, but it is a way of bringing new knowledge into clinical practice even before physicians realize that they have an information need. Can it work? Yes, it can. And I think we illustrated this with a study on the prescribing of laboratory test ordering. And what is the setting here? Know that I think maybe 5 years ago, maybe a little bit less, and maybe for some clinicians this is still a fact. A lot of laboratory tests are ordered on a paper-based order form, where you just tick boxes in, and this paper-based order form then goes to the lab. The lab scans it in best case. In some cases, they have to manually impute the tests into a system. And this type of work, or this manual work, and at least this paper-based work, is not really efficient for enabling clinical decision support. But more and more, laboratory test ordering is migrating to an online platform where the physician orders the test on a computer-based form. And here we have opportunities, because now we're looking at structured data. We have a test which has a code, we have patients that are electronically identified, and now we can enable decision support. And the decision support that we tested in the ELMO study, and I apologize because this is probably too small to read, but it starts from a very different idea. Rather than ordering tests, the decision support asks you, queries you, what is the reason why you're ordering tests? What are the indications, and what are the conditions, or what are the complaints that the patient is presenting with that has prompted you to order lab tests? And based on the information that is ordered here in the computer physician order entry, the decision support service suggests a series of tests based on a knowledge base of clinical guidelines that suggest certain tests in certain clinical scenarios. And this type of clinical decision support we tested in a study, and again the study I'll come back to in a little bit later, and we saw that this can work, and it worked quite well. And unfortunately, we saw that appropriateness of laboratory test ordering in the control arm was really, really low. I'm talking about only 1 in 3 tests being appropriate, and in the decision support arm, this was a lot higher. More than half of the tests were appropriate. But how we conducted this research, I will go into in just a little bit. What are other possibilities? And now we're looking at the non-knowledge-based clinical decision support systems, and these are often based on what's so-called neural networks, where the only thing that we see as a clinician or as a researcher is an input layer and an output layer. We know what we're inputting into the system, we know what the system is bringing back to us. But within the neural network, there are a whole series of hidden layers that search for associations between these layers, and from these calculations, derivations are made that can generate new information. This is a very promising stuff, this type of artificial intelligence. There are certainly some challenges still that need to be looked at before we can really talk about this type of non-knowledge-based decision support breaking through in healthcare. It has found its way in some types of illustrations, and often it has to do with imaging, because images are those things that neural networks have the best experience with today. But if we want to use it on other types of data, then data quality becomes very much an issue. And is everything that the neural network needs really available in a structured format? Transparency is also something which is still a challenge. There was a publication a few years ago on something called the clever hands phenomenon. Where Hans comes from the story of Hansel and Gretel, who used a chicken bone to fool the witch that he wasn't growing fat, despite the fact that he was growing fat. And here the use case was, I think it was the Mayo Clinic that had developed an algorithm based on neural networks to try and identify high-risk patients based on chest X-rays. And this neural network was unbelievably good at identifying patients who were administered to the ICU versus patients who weren't administered to the ICU. But when they tried this neural network in different hospitals, it failed completely. And apparently what turns out that the neural network didn't use any information from the chest X-ray itself, but actually used information on which machine was being used. And the neural network found that every time that a patient was being X-rayed by the machine in the ICU, that was associated with a high-risk patient. So it didn't actually use any of the information that it was intended to use, but it used other metadata. And those are the type of things that you don't really see because it's within these hidden layers. So these are types of things that we need to work on how we can prevent it from happening. And then the last thing, which is very important with non-knowledge-based clinical decision support, is accountability. And who's accountable if there is a problem with the decision support and that it has inflicted patient harm rather than patient care. And one of the research that I'm now starting with a PhD student after the summer is sort of a follow-up on the ELMO study, where we want to use big data on laboratory test ordering to try and predict low-value lab test orders based on the indications and the results from previous lab test results, so that you have an additional step in the clinical decision support system, which is actually more than just knowledge-based. Subsequently, we have this infrastructure for evaluation. I think this is very, very important in a learning health system. We need a platform, we need an infrastructure that allows us to start this efferent part of the cycle. And we need a way to collect this data from the learning health system that enables analysis, that enables evidence generation. And this infrastructure needs to be safe, it needs to be secure, and these are things which GDPR has included as requirements, but also, and I think that's a very important one, this type of infrastructure needs to enable the duty to inform patients that their data is being used in evaluations within the learning health system. The system that we were involved in developing and implementing especially is the system which is currently being used by Cienzano, and many of you have probably seen many applications of this within the current COVID-19 statistics. These are all statistics that are collected using this infrastructure. And the idea of this infrastructure, and I'm going to go through it not that detailed, but the idea is that there is a primary system which collects data from routine healthcare, and this primary system has an additional system installed, which they call high HD for data providers, and it captures the data that we want in our learning health system. So it captures, in essence, routinely collected health data and would try and allows the additional information which would not be routinely collected, but that's not the idea. The idea is to collect only that data which is really routinely collected within the primary system. This data is then coded and encrypted and is sent and pseudonymized during that process and sent to CNSANO, where the infrastructure is called health data. And there it's integrated in the data warehouse, which is SaaS Enterprise Guide based, where you can do all sorts of data analysis. And then the aggregated data can then be sent to HealthStat, where it allows reporting. And these are the reports that you can, for instance, see in the national news website, where you have all the graphs on the COVID-19 pandemic. All that data has gone through this series of steps and is collected using these methods. There are some challenges. We used this method as well for the ELMO study. We've used or attempted to use this method also for the diabetes trial. There's some other trials that we looked at health data as a means for collecting data. There's also we use this method for collecting data for the Intego database, which is a primary care morbidity registry, which is run at the Academic Center of General Practice as well. And there are some challenges because this infrastructure relies heavily on the data at the primary source, and any data which is unstructured at the primary source will remain unstructured and will not be captured by this infrastructure. So the key to having data quality here is having structured data at the primary source. And so a challenge will be and will remain to be having a lot of the unstructured data, which will always be part of routine healthcare, but how can we ensure that the maximal amount of unstructured data can find its way into structured entities? And I think natural language processing certainly has some opportunities there, and there are certainly other ways or other opportunities in data communication between healthcare providers to improve the structured data at the primary source. Obviously, you saw in this diagram that there are a lot of parts in this chain of data communication. Unfortunately, a large chain implies that in any one of those individual parts of the chain, you can have troubleshooting, technical troubleshooting. We have experienced some of that in the ELMO trial, which was very frustrating because we needed to resend a lot of the information, sometimes up to 3 times. And then another challenge, and I think this is something which is often overlooked, is cementing interoperability. And what I mean with that is you can have a data element which seems to be identical, but actually in 2 different primary sources means something else. And I'll give an example. If you have a primary source which a clinician has coded 2 contacts of a patient, and he codes, for instance, a pneumonia twice, then when you send this data to the infrastructure, it appears that this patient has had 2 contacts for pneumonia, and could mean that he had two episodes of pneumonia. However, in other instances, this data could be interlinked, where that it's clear that it's actually 2 contacts concerning the same episode. So you have the same data point, but in one situation, it's only 1 episode of pneumonia. From another system, it would seem like 2 episodes of pneumonia. So it doesn't mean the same thing, despite the fact that it's the same data element. However, this infrastructure does have some opportunities. It allows linking from data across systems with the LHS, within the learning health system. In the ELMO trial, we linked the data from a laboratory information system with EHR data for identical patients without compromising their identity. And it also has some potential for study designs, and that's the next section of my lecture. However, what we don't have today, and I think it's a very important part, is it does not yet allow our duty to inform patients that their data is being used for clinical research. And I think that's going to be an important next step in this in the CIUSANO database, to inform patients that their data is being used. In COVID-19, this was circumvented, but I think in many other applications, this is going to remain an important challenge and opportunity. Now, how can we create evidence in a learning health system? And here the buzzword is real-world evidence. And I think many of you have heard of this word before, and I would like to argue today that there is no such thing as real-world evidence. And I think that there is real-world data, which is often referred to as routinely collected data, and there is such thing as evidence, but evidence derived from routinely collected data shouldn't be any different than evidence derived from a true trial-based data collection. However, I'm very much convinced that real-world data has some important opportunities. This is a table from a review by the people working with John Ioannidis, where he propagates very strongly on using routinely collected data to as data analysis or data or outcome collection, because it has some important opportunities. The outcomes that you're collecting are often, because they're rooted in routinely collected data, are often a lot more relevant to patients. It drives research towards more understudied healthcare questions. And the access to this data is a lot more easy than if you have to query or you have to collect this data using using trial nurses or whatever. There is the possibility, at least the opportunity, that it's more generalizable. You have the opportunity of directing your research to more specific conditions or subgroups. And however, there are some very important challenges, and I think the most important is data quality. Often the real-world data is not collected with the same rigor as data collected for clinical trials, and then there need to be systems in place to ensure that there is a maximal data quality. And the real-world evidence should drive our research, but on the other hand, real-world data should also reflect what patients consider to be important. So if we're not collecting what patients consider important, then it's no use in using real-world data either. And I'd quickly like to illustrate how we did this in the ELMO study. So we used data from the EHR and from the laboratory information system. We did not collect any data outside, or at least a minimal amount of data outside of what was already routinely collected in primary healthcare. And in that infrastructure, in that setting, we designed a cluster randomized trial, and that included more than 10,000 patients and included almost 300 GPs. And over a period of 6 months, we collected data on more than 300,000 lab tests. And from this information, what were the main, I think, opportunities? It was we were able to run a really big trial at the costs of a much smaller trial. And so I think that there was certainly a cost savings aspect. The time between the acceptance of the protocol by the funder and the first patient in was less than 5 months. So the trial preparation was a lot smaller than the trial preparation would have been if we had to enable all types of data collection specific for this study. So it certainly sped up the possibility of doing research. We did have some issues regarding data quality. We had some issues regarding possible documentation bias, which we had to correct for in our analyses. We also had some problems with the technical issues, in which case we had to send GP trainees and medical students to all the different practices to do the automated data collection themselves. But again, this would have been a lot more cumbersome if we had to interview 10,655 patients in diverse stages of the trial. This would have been a lot more time and resource demanding. we were able to also not only monitor what we expected the effect on appropriateness, we were also in this study able to add new evidence, which I think was globally pertinent as well. And that was the question, are these types of systems that drive laboratory test ordering and often, like we said, improve appropriateness, but also make it so that physicians order less tests, is that not associated with the risk of missing out on important diagnoses? So we included an extra outcome measure where we wanted to know, is it a safe system? Do we miss new diagnoses? And with this study, we were able to say that using a clinical decision support system that improves appropriateness and reduces volume of laboratory test ordering does not influence diagnostic error, which I think was very innovative and new for this type of clinical decision support systems. Yeah. If you look back at the rapid recommendation for the schools in COVID-19, on the lower left-hand side of the slide, you see this type of data that you probably see in the media almost every day. And this is real world data. This is data directly from laboratories. This is data directly from hospitals. This is data directly from primary care physicians. There has been no specific data collection for these type of registries. This is routine healthcare data, which is monitored on a daily basis. And we used this data to formulate advice on either to not close schools during the COVID-19 pandemic. We also used routinely collected data for the potential harms. We wanted to know what the effect was on learning delay. We wanted to know what the effect was on mental health, on child abuse, on domestic violence. And these were all information that we collected from routinely collected health data. We did not use any specific data that was collected in the scope of a research question or a research project. So it is possible to use routinely collected health data to formulate recommendations. However, it is important to illustrate the limitations of this data and the insecurities that there are in evaluating or appraising this data. And I think we like you see here on the right side, this infographic is in Dutch, but there will be one in English as well, is that the certainty of evidence for almost all of these outcomes was very low. But still, despite this lack of certainty of evidence, we were able to come to a strong recommendation in favor of keeping schools open despite the COVID-19 pandemic. And this will be published very soon. I've come to the end of my lecture. There's some key messages which I think I would like to go home with. Evidence synthesis and evidence disseminations are largely global, and I think that we need to emphasize strategies to reduce waste and to improve clinician understanding of using this type of evidence in clinical practice. Like I said, clinical decision support systems, it seems like they're not really delivering what they have promised, but still there are some promising research results for clinical decision support systems, and especially when we look at the new non-knowledge-based applications, and there is, I think, a whole research domain opening on that side as well. Routinely collected data can optimize clinical research, and I'm very much convinced that clinical research can benefit strongly from integrating routinely collected data as an important outcome measure and an outcome data collection. And finally, if you're interested in any of the things that I've discussed today, then please reach out to me, and you know where to find me. Thank you for listening, and it was great to be able to discuss these things, which I find very, very interesting and fun.
Thank you very much, Nicolas. We record the sessions, so people who want to look and see maybe some bits of it again can watch it. We will communicate where it will be available quite soon. I'm afraid we don't have much time for questions, but if somebody has a pressing question, they can raise their hand and unmute themselves to ask a question. Otherwise, you can always contact Nicolas himself, I assume.
Absolutely.
Thank you very much, Nicolas, and see you all hopefully soon in life. Thank you. Bye-bye.
Thank you. Bye-bye.
Bye-bye.